Thank you for that kind introduction, and I would like to thank the organizers of the Great Wall International Congress of Cardiology and the Asian Heart Society Congress for inviting us, and we'll be transitioning now to the heart failure topic. Are you able to see my slides?
Yes, we can.
Perfect. This past year, JACC Heart Failure had a new editorial board, and I have the honor to lead as the editor-in-chief. And with our new board, we had new strategic initiatives, one of which was to be more global. The other one to expand the areas of focus beyond heart failure to include pre-heart failure prevention, as Dr. Fuster alluded to, as well as advanced heart failure, cardiac transplantation, cardiogenic shock, pulmonary hypertension. And we included new paper types such as research letters, along with state-of-the-art reviews, expert panel consensus statements, and special issues, which I will elaborate in the next few slides. The topics we focused on, of course, entailed the standard therapies for heart failure, including the quadruple therapy. We had a network meta-analysis of all the pharmacological treatments, looking at all clinical trials with guideline-directed therapies. And this meta-analysis was one of the most highly cited papers past year, demonstrating quadruple therapy with SGLT2 inhibitor, ARNI, MRA, and beta blocker confers approximately a 61% reduction in all-cause mortality. Again, this is imputed, this is network meta-analysis, but demonstrating a mathematical calculated risk reduction with use of these four agents, which validates the class 1 recommendation, the guidelines for using quadruple therapy as the first step in treatment of heart failure with reduced EF. We then published a variety of papers demonstrating efficacy with some of these new agents, such as SGLT2 inhibitors, across the EF subclassifications, such as mildly reduced EF, as well as preserved EF, and other risk subgroups, such as those individuals with chronic kidney disease or individuals with high risk profiles. Across all of these subgroup analyses, ARNI as well as SGLT2 inhibitors appeared effective. And these also are represented and supported by the guideline recommendations for these agents to be used across all subgroups of patients, regardless of race, ethnicity, gender in the heart failure spectrum. In editorials, we emphasized the strategies for optimization of heart failure therapy. In addition to the quadruple therapy, which I make the analogy to induction chemotherapy, like we do induction therapy in cancer, the quadruple therapy in heart failure is very similar to initiation of this disease-modifying agents to change the trajectory of the patient's prognosis early on. And then add-on therapies with agents such as ivabradine, vericiguat, or devices as consolidation therapies. And of course, treatment of comorbidities, which need to be initiated early on, have specific recommendations for atrial fibrillation, for valvular heart disease, and now with obesity in heart failure. In terms of the barriers to care in the JACC Heart Failure Journal platform, we tried to cover the reasons for discontinuation. On this slide, we do see that the newer agents, such as SGLT2 inhibitor and ARNI, utilization came after the traditional medication blockers, ACE inhibitors, and took more than a year for up-titration, and a significant proportion of these agents actually were discontinued. And some of these discontinuations were permanent, some of them were switched to other agents. We also covered the tolerability being low in individuals who demonstrate baseline comorbidities and advanced heart failure state. Shown on this slide is tolerability of sacubitril valsartan in the LIFE trial, which was conducted in NYHA class 4 heart failure patients, demonstrating that those individuals who had borderline low blood pressure, those individuals who could not tolerate ACE or ACE inhibitors or ARBs, or those individuals who had severe heart failure with moderate MR were the ones who developed intolerance and inability to uptitrate these medications. 18% of the patients in the LIFE trial were intolerant to sacubitril valsartan. New models of care is an important topic in JACC heart failure. We covered the newer modalities for implementation of guideline-directed therapies, which now include multidisciplinary care along with telehealth and even patient self-uptitration as potential novel methodologies by which the guidelines can be uptitrated. We have a new corner called the mechanisms and methodology and try to cover how some of these new agents result in improvement. One of the areas of intrigue for us is how the SGLT2 inhibitors work, and demonstrated on this study that the SGLT2 inhibitors were associated with reduction in epicardial adipose tissue, as well as extracellular cardiac volume, matrix volume, and inflammatory biomarkers suggesting structural changes along with cardiometabolic changes with these agents, even in patients without diabetes. And we had a very important state-of-the-art review paper on how to manage heart failure with preserved ejection fraction and specified use of SGLT2 inhibitors as a first-line treatment in patients with HFpEF, even before the recent update in the heart failure guidelines. As represented on this slide, the heart failure with preserved EF therapy now includes SGLT2 inhibitors, and the other agents have class 2B recommendations. In a very important real-world patient analysis, we demonstrated that beta blocker use is not associated with improved outcomes in patients with heart failure with preserved EF. And if anything, there could be an association with increased risk as the EF is increasing, suggesting that beta blockers are indicated in heart failure with reduced EF and mild reduced EF, but do not have any significant benefit in patients with heart failure with preserved EF. There are a variety of papers covering the efficacy of treatment strategies in patients with cardiomyopathy. Shown on this slide is the role of SGLT2 inhibitors in patients with chemotherapy-related cardiomyopathy. We recently covered the design of a very important trial called the STEP-HFpEF, and this is a study looking at the efficacy of semaglutide, a GLP-1 receptor agonist, in patients with obesity and heart failure with preserved EF, majority of which were in NYHA class 2 heart failure status with average BMI of 37, with elevated anti-proBNP levels and very poor quality of life and 6-minute walk distance. When treated with semaglutide, we saw significant improvement in their overall quality of life, as well as reduction in body weight, accompanied with reduction in NT-proBNP and CRP, creating the new paradigm shift of potential utilization of weight loss agents in patients with heart failure with preserved EF. But we are awaiting further studies to demonstrate hard endpoint improvements with these agents, as well as efficacy and safety in patients with heart failure with reduced EF. And in the journal, we had a variety of papers demonstrating the role of new strategies for identifying pre-heart failure. Biomarker approach is very important in the new definition of heart failure. For pre-heart failure, NT-proBNP or cardiac troponin elevation is a diagnostic criteria, and this study actually demonstrated how clustering of biomarkers was associated with higher risk. And very interestingly, we did see evidence for abnormal diastolic dysfunction in the setting of atrial fibrillation patients who are without diagnosis of HFpEF, and thus, if one were to look at their cardiac mechanics, lower LA left atrial compliance, those individuals that are referred for AFib ablation can, in majority, be diagnosed with HFpEF and potentially could be treated with HFpEF treatment strategies. There are a variety of papers looking at the role of screening for genetics in dilated cardiomyopathy. In this study, family screening identified genetic predisposition in only a third of the patients with familial cardiomyopathy. And in those individuals, when the baseline echo and EKG were normal, subsequent surveillance did not result in any further risk of dilated cardiomyopathy development, suggesting that a genetic screening for familial cardiomyopathy can identify the subgroup of patients in whom surveillance imaging may need to be conducted. And of course, there is an evolving field of recognition of position in individuals with acute myocarditis and the role for genetic testing for risk prediction. And on the VAD transplant side, we have a variety of papers showing risk prediction models, which actually was one of our scholars who won the Chris O'Connor Award for Outstanding Scholarship, along with a former presenter that I showed, who did develop the family screening approach in the dilated cardiomyopathy. And non-invasive cardiac transplantation rejection surveillance is an important topic for us. This review reviewed the role of the donor-derived cell-free DNA as a strategy to biopsy in cardiac transplantation screening. And finally, we have a variety of papers looking at the differences both in Takotsubo cardiomyopathy. In this paper, the emotional trigger being a pleasant trigger was associated with similar outcomes as those who had negative triggers. So the happy hearts had very similar outcomes as the broken hearts. And the bereavement and death of a family member was associated with increased mortality rates in a significant proportion of our heart failure patients. And of course, as my colleagues have mentioned, machine learning as well as deep learning prediction models are very important, and wearable devices do provide a big platform for us for remote monitoring as well as for artificial intelligence. We have specific issues. We did have a technology and heart failure therapeutics issue. We have a variety of state-of-the-art reviews ranging from mitral aortic tricuspid regurgitation, as well as structural interventions such as flanking nerve ablation. And the most recent one is heart failure in women, which covers the approaches in management of heart failure in pregnancy, and that female reproductive factors such as younger age at menarche or menopause being risk factors for heart failure, and that the gender differences in how women receive care across the globe reflects disparities and the reasons for worse outcomes for women. And our podcasts and videos are other portals by which we try to reach globally. And I would like to finish by thanking my editors, our reviewers, our authors, and our readership across the globe.